Thank you. Our lecture will be imaging of primary immune deficiency disease in pediatrics. Primary immune deficiency encompasses a group of diseases caused by genetic defects in immune system development and or function. Primary immune deficiencies can be classified more broadly based on abnormalities of adaptive immunity, T cell, B cell, or combined immune deficiency, or innate immunity as phagocyte and complement disorders. When to suspect a child presented with recurrent infections or opportunistic infections? Primary cellular immune deficiency can lead to autoimmunity, infections, and cancer. Can cause multiple pulmonary disorders, autoimmune diseases, and gastrointestinal complications, and are at risk of development of lymphoproliferative disorders and social malignant tumors. The next slide will show different body system affection in patients with primary immune deficiency. First of all, the central nervous system. Case 1. An adolescent with hyper IgM syndrome presented with fever and convulsions. MRI shows abnormally enlarged perivascular spaces in the basal ganglia bilaterally, seen in T2, and post-contrast choroid plexus and laryngeal enhancement. The final diagnosis was cryptococcal meningitis. Case 2. A 13-month-old presented with irritability, fever, and convulsions, known after that to have neutrophil-specific granule deficiency. CT brain with contrast shows a large left parietal cavitary abscess with inflammatory sediment, left hemispheric edema, ventricular compression, severe mass effect, and midline shift. The final diagnosis was brain abscess. Case 3. A 6-year-old boy presented with night fever and disturbed conscious level. CT brain without contrast shows right periventricular space occupying lesion with a smaller left frontal one with adjacent vasogenic edema. MRI brain shows bilateral cerebral more at right side space occupying lesions with adjacent variable degrees of vasogenic edema showing peripheral wall enhancement. Contrast AMD shows mild basal and convexity of smooth patchy meningeal thickening and enhancement. The final diagnosis was multiple brain tuberculomas with TB meningitis. Case 4. A 4-year-old boy, non-chronic granulomatous disease, presented with fever and scalp swelling. CT brain without contrast shows an isodense scalp soft tissue lesion with underlying left occipital cortical irregularities. MRI was done to detect any cerebral lesions and it was free and confirms the presence of a scalp lesion showing intense post-contrast enhancement. The final diagnosis was fungal infection in the scalp. Biopsy culture and sensitivity confirms fungal infection and antifungal drugs were given. So, brain infection, whether primary affection, direct spread from scalp or paranasal sinuses, or blood spread from distant organs as osteomyelitis. Second system, paranasal sinuses. Case 1. A 14-year-old girl with hyper IgM syndrome. Coronal CT image through the midface showed mucosal thickening of the maxillary sinuses as well as near complete opacification of the ethmoid air cells. Marked thickening of the nasopharyngeal mucosa is also evident. The final diagnosis was sinusitis. Note, features of fungal sinusitis include opacification of the sinus by soft tissue attenuation, motile lucency or irregular bone destruction may be seen, fat stranding outside the sinus, intraorbital fat, and relative lack of expansion of sinuses. Chest. Case 1. A 4-year-old boy, non-chronic granulomatous disease, presented with cough. Chest X-ray shows right upper and mid-zonal opacity with left-sided scattered opacities. CT chest shows multiple variable size nodules, some of them are cavitary, with right middle loop confluent area of consolidation. The final diagnosis confirmed by bronchoalveolar lavage was bilateral lungs fungal affection with superadded bacterial pneumonia. Case 2. A 9-year-old female with combined immune deficiency with history of cough, fever, and recurrent pneumonia since the age of infancy. CT with contrast shows multiple bronchiectasis, varicose and cylindrical, with bronchial thickening and some nodular opacity with twinning pattern, and others with ground glass opacities, mosaic pattern, and septal thickening. The final diagnosis was lymphocytic interstitial pneumonia. Case 3, known case of D. George syndrome, and chest X-ray shows narrow superior mediastinum with absent thymic shadow. The final diagnosis was congenital athymia. Musculoskeletal. Case 1, known case of hyper-IgA syndrome presented with back pain. CT lumbosacral spine sagittal view shows a compression deformity of the T12 vertebral body, likely due to syndrome-related osteoporosis. Case 2, and 1.5 month female presented with limited range of motion for her right shoulder. X-ray right shoulder shows a lucent lesion with possible cortical disruption of dorsal in the head of the humerus and periosteal reaction in the proximal third of the humerus. Ultrasound study revealed hyperechoic fluid in the shoulder joint. Coronal stir series showed high signal around the humeral head and high signal in the bone marrow of the proximal third of the shaft. The final diagnosis was right shoulder septic arthritis in combination with osteomyelitis of the proximal humerus. Gastrointestinal tract. Case 1, an 8-year-old male, known ataxia telangiectasia. Unfortunately, CT was done. An axial CT image without contrast demonstrates diffuse wall thickening of the stomach with preserved lumen. The final diagnosis was mucosa-associated lymphoid tissue lymphoma. Case 2, a patient known as X-linked agammaglobulinemia presented with abdominal pain and bloody diarrhea. Intravenous and oral contrast-enhanced axial CT images through the pelvis demonstrate terminal ileum diffuse mural thickening together with punctate foci of air extending through the anterior abdominal wall musculature into the subcutaneous fat. The final diagnosis was Crohn's disease with anterior cutaneous fistula. Case 3, a 3-year-old female known immunodeficiency presented with right hypochondrial pain. Ultrasound shows a hypoechoic hepatic focal lesion with irregular borders and internal debris inside. CT with contrast shows a hypodense air fluid-filled hepatic focal lesion with irregular margins with peripheral rim of enhancement. The final diagnosis was hepatic abscess. To summarize, primary immune deficiencies result from a wide variety of molecular defects that adversely affect the development and function of the immune system, results in the variability of clinical and radiological features. All body systems may be affected whether by infections, autoimmune disorders, or malignancies. A radiologist's familiarity with these primary immune deficiency diseases and associated imaging findings is essential, as imaging plays an integral role in both diagnosis and surveillance. Thank you.